Smith, and I'm here with Chris Norman, Carrie Johnson, and Michael Oyster. We're here to talk about the home CCO enrollment rule for adult mental health residential treatment transition. Our objectives for today are that you can understand the origins and importance of the home CCO enrollment, also to recognize challenges and opportunities that home CCO enrollment brings to the residential treatment system, and to start a conversation about how, with us working together, we can come up with effective solutions and best practices. So I'm going to go ahead and hand things over to Chris Norman.
Good morning, everybody. This is Chris Norman. I am the Delivery Support Unit Manager for Health Systems here at our goal here today is to talk about a new rule, but also a little bit of staging. So the slide you have up here, I think most of you on the phone, hopefully all of you on the phone, are well aware of the move we're going into coordinated care, the track that we've been on for the past 4 years, starting in 2012. And it's all about the right service at the right time, at the right setting, the appropriate length of time, and integrating all those services around the member. One of the key pieces to CCOs and the coordination of care is transitioning the mental health residential treatment into coordinated care. That is the last major piece of the coordinated care system that we're currently tracking towards July of 2017. Again, you can see here with our slide kind of what we talked about before. One of the key parts of that is one of the things we're talking about today. And so as people are currently in CCOs and leave the state hospital, there's a component to the residential care that they will be going into. And so I'd like to introduce Michael Oyster, who will talk a little bit about the importance of residential care.
Hi, everyone. This is Michael Oyster. I'm the AIM High Coordinator for Health Systems under the Oregon Health Authority. The importance of residential care is really, there's two functions about this process. The first function is really to promote and enhance skills. The patient really needs to have the skills to live the most independent life possible and be able to enjoy the health that comes from that process. It really builds on skills that's been learned at the hospital and in the community previous to that hospitalization, so that the skill building happens over time and is built on previous skills. The second point is that it's really about returning the patient to their home community. It's really to develop the skills to progress to a life beyond residential treatment. Just like the hospital's role of preparing the patient for the community, residential treatment prepares the patient for lower levels of care. In other words, more independent living.
All right. Our next slide talks about when those folks, as Michael mentioned, transition from the mental health residential treatment into coordinated care. Again, when people leave the Oregon State Hospital, those services are temporary. They're going to go out of the area, receive mental health residential, and then transition back to their home CCO and their home county. Again, those services aren't always available in the same county where their CCO might be located. So depending on what time they leave or what services they need, they may be temporarily placed in an area that's across the state. But, and this is where it's important for that CCO to still be enrolled, or that member to still be enrolled in their home CCO, having that one CCO track the member, whether if they're in across the state or in the same county, they know what's going on with that member, and they can help that member transition when they come back into their home county. And there may be times where they move for more than one facility, and rather than have that member bounce from CCO to CCO, depending on where those facilities are located, it's staying with one CCO that knows that I'll use myself as a hypothetical example. If I go to Hermiston for treatment, but my CCO is based in Salem, and then I move to Portland for treatment, that way I'm not moving from a CCO that's based in Eastern Oregon to a CCO that's based in the Portland Tri-County area, and every time I move, losing that ability to understand what my treatment plan is, what other things I might have going on. And so staying with that home CCO for those temporary placements ensures that, one, there's consistency in how my coordinated care plan is covering the various other pieces of my care outside of the mental health residential, and two, make sure that whatever's happening at those various stages of my recovery is going to help me transition back home. So they know that Chris Norman's got these different things going on at these different levels of care, and they can help me when I get back because they know what's going on, they know the treatment that I've been through, and they can help me successfully transition back home. So our next slide talks about the need for the administrative rule. And in some ways, this was the process that we've been operating under, but it was not explicit in Oregon Administrative Rule. So I think for some people, this probably is something that they already have operationalized, been working under for several months. For other folks, this might be the first time they're hearing of it. So again, that was the purpose of today's webinar, is to kind of introduce the topic and talk about some of the things that we've heard coming up. The new rule around home CCO enrollment was really the next step in us moving towards the integration of adult mental health residential into CCOs for July of 17. So this is the first step in many that will lead us to that integration, but again, wanted to make sure that everybody understood what we mean by home CCO. So the next slide talks about the specific rule language, and again, I'm not going to read the slide to you, but the rule is OIR 410-141-3066, and that is a little bit more specific to when we talk about the home CCO and the specific pieces around that. It's actually effective tomorrow. It's been going through the rule process actually since late this spring. I know a number of CCOs and other stakeholders have been involved in the hearing process for that rule. A couple of the key things on the next slide around defining home CCO. So Section 1B talks about home CCO. We use that term a lot. But what it means is enrollment in a coordinated care organization in a given service area based upon a client's most recent permanent residency determined at the time of original eligibility determination or most current point of CCO enrollment prior to hospitalization. Now that's important because, again, for those that are not familiar, when people go into the Oregon State Hospital, they're not eligible for the Oregon Health Plan at that point. But a lot of them will come out of a CCO or come out of a specific area where they've lived, and that is what we're calling the home CCO. So the next slide is about temporary placement. Again, this is also a key component because when members leave the Oregon State Hospital, they're going into a temporary placement, which might be inside or outside of the service area. But the expectation is, as Michael mentioned, these are folks that are going to transition through whatever this mental health residential piece is and come home to that home CCO and be discharged and hopefully go on to be a successful member. The next slide talks about that process and how it happens to the Oregon State Hospital. I'm going to introduce Carrie Johnson, who's our Client Enrollment Services Lead, and she's going to talk a little bit about the process that the Oregon State Hospital goes through. Carrie?
So the Oregon State Hospital, the Benefit Coordination Unit consults and coordinates with the home CCOs, and the benefit coordinators review the client's enrollment history prior, about 30 to 60 days prior to the client being discharged, and at that time, the benefit coordinator will notify the account representative so the home CCO can engage in the client's coordination of care and transitioning out of the state hospital. Clients without enrollment history will be enrolled based on the permanent residency. And if client does not have permanent residency or they do not have the enrollment history, the client will be placed in the service area, and so this is where the residential facility will be located. The benefit coordinator unit is also responsible for determining client's home CCO based on specific criteria, and they're responsible for ensuring that the client has active eligibility and enrollment at date of discharge, so they have a smooth transition into these residential facilities, and they are ensured to have medication when they leave the state hospital, and the facility can appropriately coordinate the care and bill for services. And I'm going to, Michael Oyster is going to be talking to you next about the process at discharge.
So when the patient is admitted to the Oregon State Hospital system, it is at admission that discharge planning begins. It always begins at the beginning. So the Oregon State Hospital staff will identify the home CCO and then notify the AIM-HI, the Adult Mental Health Initiative coordinators, as well as county mental health, to be able to follow through and coordinate care for the patient as they come through the hospital system. That's bringing information as well as learning from previous placements. 30 to 60 days before discharge, the staff at the hospital will request an expedited OHP eligibility so that the patient has coverage the very day they leave the hospital. That's really critical. The hospital level of care is the highest level of behavioral health care we have. It's important that once a patient receives that care, they have all the supports needed to bring that information out with them into the community. Then the home CCO is notified and the engagement process begins at that time with them.
On the next slide, we know that there are some challenges with home CCO enrollment. Part of the issues that we know for this population of about 1,800 people is, one, permanent addresses get changed. So that's been our biggest challenge right now, and you may have heard this referred to as flipping, where members will flip out of their home CCO and into whatever CCO happens to be for the residents or the address for the facility that they're in. Again, the key here, and we're working through the various system pieces of this, is to make sure that we understand that the permanent residence is where that home CCO is. A mailing address might change. We know there's some other challenges with the various systems that we're working through right now. But again, the goal is, if the mailing address is for the facility, the permanent address needs to stay for that home CCO location. The second challenge that we know of is that the CCO service areas and provider networks don't include all adult residential facilities, and not all CCO service areas have those facilities or the special programs. The other thing we know is that CCOs aren't contracted statewide to provide the primary care, dental care, and other services that members need when they're in those temporary locations. Again, we've been working with CCOs since last year on this, but we know that facilities see this on the other end. And I think the last thing is that more coordination is definitely between CCOs and out-of-area providers. We do have some processes in place, but one of the things that we anticipate from today's webinar is that we'll have some more examples of things where we can do better. We know that some CCOs are doing a great job of reaching out to other areas of the state. We know that some haven't started that process yet. And the next slide talks about some of the strategies that we're going to go through and some other resources that will be available around how we can ensure that successful coordination of care. So one, of course, is the implementation of the home CCO rule, which we're talking about today, and to some degree has already started. The Oregon State Hospital discharge planning that Carrie and Michael talked about, that has begun. It has begun pretty recently. I believe that training happened just in the beginning part of the summer, so we're just now beginning to see those. So if you have examples of things that happened maybe last year or earlier this spring, that process hadn't taken effect yet. So you will begin to see that as we go forward. Staff guidance on address changes. So one of the things that we mentioned just a few slides ago is some of the challenges around knowing when an address change is because a person moved and knowing when it's just because their mailing address changed while they're temporarily out of the area. Again, the goal of today's webinar wasn't to answer every single question. I'm sure there will be some. Part of this is just to introduce the concept of home CCO rule. I think one of the things that we'll see as we go forward is the need for, and we've got one scheduled for Wednesday, September 23rd, what other kinds of things are out there? What other questions do you, stakeholders, providers, CCOs have around how this is going to work, things that you're seeing, things that are working, things that are not. So we're going to have monthly provider calls to share some best practices, help us to problem solve. We would certainly welcome your emails directly, and we will have an ongoing FAQ based upon questions from today and future emails and other meetings that we're going to have about what some of those challenges are and what some best practices are that we can share as a group. So with that, I think, again, most of what we're doing today is how we can work better together, what kinds of questions you have. We will try and answer some of them, but a lot of what we're looking for today is what are the things that you would see that are barriers, what kinds of things have you experienced that have worked well, We will take that back and come up with some FAQs, topics for future discussions, and this is really just the beginning of a conversation. So with that, Jennifer, I will turn it over to you for the Q&A.
Right, so the slide that's up now is just contact information if you have any questions or discussion items about this rule. Also, you can keep informed at that website there, and we'll just leave this up so you can copy that down. And also, you should have gotten a copy of the slides at about 9 o'clock this morning. I sent them out to everyone who was registered. If there's anyone on the line that did not receive the presentation, if you want to go ahead and type your email address into the questions area, I'll make sure you get that after the presentation today. So let's go ahead and start taking some questions. All right, so first question, what do you mean by temporary? I work with PSRB and may have someone for several years in residential and placed in independent living. How would the CCO manage this?
So that's a great question. We've heard that before, that some of these, when they leave the state hospital, what may be a temporary location may turn into something longer. I think that's one of the things that we're working through right now is the operational pieces of what that determination looks like. So that is something that we'll add to the FAQ as we go forward. But at least today we don't have there's an annual review process that people look at for determination for OHP benefits. So one of the things we're looking at is how we use that process to establish when that goes from a temporary to something else. But we'll definitely follow up in the FAQs on that.
Okay, next question. Is the term county of responsibility no longer being used?
So that's a great question. I know that's something that our AIM high vendors are definitely familiar with. I know a lot of the mental health professionals are familiar with. For the purposes of the enrollment rule, we're really using home CCO because that is, from an enrollment standpoint, what we're considering. So it's not that we're not using that anymore, but for the purposes of the enrollment rule today, we're really using the concept of home CCO.
Also, as it relates to the contract, the references the AIM High coordinator, that's being emphasized in the contracts, not necessarily county of responsibility. Not that the function has changed.
Thank you. Next question. Regarding the expectation to return to the home CCO, what if an individual wants to move to the temporary area that they have been receiving treatment in?
Another great question. So it depends on what their, I guess, level of security or oversight is when they are in treatment. So there are members that can make their own decisions about where they want to be, and for that particular member, if they determine that maybe they're from Medford, but they really like the Eugene area, which is where the facility is, and they get to make the decision of that, certainly they can. And just like any other member, they can call and say, you know what, I've moved to Eugene, this is my new permanent address, and we can make that change just like we do for all members all day long. I think the question is if that member does not get to make a choice, so if it's, trying to think, PSRB would be an example of that, or another civil commitment, those people actually probably don't get to make that decision. So in that case, there might be a point when they're no longer under civil commitment, and that would be the decision point then. For people under civil commitment, that isn't a choice that they have right now.
Okay, next question. Will clients still have open card for a few weeks before they get a home CCO? And for those of you who don't know, open card is the same thing as a fee for service. That's where you would bill us directly here at OHP.
Oh, yeah. So the procedure that we've been working with the state hospital, the benefit coordinators are actually supposed to be working with eligibility 60 days prior to the client being discharged to have the eligibility enrollment set on date of discharge. So hopefully there will be no situations where we will have open card fee for service. The client will be leaving the state hospital with all of the benefits that they need.
Next question, what is considered permanent residency?
I believe that's defined in the enrollment rule. I don't actually have that in front of me, but I will be happy to follow up with that one in the FAQs.
Next question, clarification on the third bullet of slide 11. Let me get back to slide 11 real quick for everyone. And we're looking at the third bullet. If there is no previous enrollment history and no permanent residency, then the client will be open to the CCO where the residential treatment home is located. Is that correct?
Yes. They will be, the client will then be enrolled into the facility, the home CCO where the facility is located. That's correct.
And that would be an example, Carrie, where someone has never been an OHP before, maybe brand new to the state of Oregon. We really have nothing that we can say that this person belongs in one area or another.
Yeah, we can't determine their residency or enrollment history. Then we would go with
the facility.
The facility.
Next question, as the AIM High coordinator begins the discharge process at admit, are they contacting the current CCO at that time or only at discharge?
They really should be contacting the CCO at that time. CCOs right now are engaging in the process at various times. We're really wanting to encourage the CCO to be a part of the process as early as possible.
Next question, who will be responsible to fix CCO enrollment when a member flips?
So that's something where they can email the Client Enrollment Services Department, and I believe that was I know it was on the memo that went out on August 11th, but that email address is ces.dmap, D-M-A-P, @state.or.us. And what we'll need to know is, obviously, the member's ID, date of birth, what the CCO was supposed to be, and the date that enrollment changed, and we will research that. We are currently doing this right now, so we would expect to continue to do that. Anything else, Carrie?
Next question, will we continue to maintain county of responsibility and home CCO?
So again, as we talked about before, the definition from enrollment is really going to home CCO. I think that the other elements that have county responsibility as the AIM contract or other places, we'll continue to evaluate that. I think at this point we're continuing them both, but I think there is a conversation we need to have about where they don't align. We think right now with the enrollment rule that we've taken that into account, but if you find areas where that doesn't, please shoot us an email. We're happy to include that in FAQs.
Okay, next question, what role will the CCOs have for residents living in adult foster homes?
So right now, I think the role is not changing. So to be clear, we're really just talking about the enrollment rule as people leave the Oregon State Hospital. There's a lot of work that we have to do between now and July of 2017 as we look to implement CCOs and mental health residential completely. Adult foster home is definitely one of those. I think maybe I'm not understanding the person's question, and if that person can maybe give us some additional clarification through the chat box. I think right now, there it is, or what services will the CCOs provide, or hands-on do for the residents of an adult foster home. Again, right now, that's really the adult foster home doing that. So I think that from an enrollment standpoint, that won't necessarily change. Other than the existing mental health residential programs, and Michael, you had
Yeah, you know, there might be a distinction trying to be made between an adult foster home and a residential treatment program.
Okay.
And really, you know, the adult foster home is a step lower than the residential treatment programs, but they serve the same function, actually. They still stabilize, train skills and the such, and move the patient to a lower level of care if at all possible. So just a foster home itself isn't necessarily a permanent placement.
Next question, does this include PSRB plans?
It does. We had talked about them and if this made sense for them. I think right now, again, that population is very small. In talking with some of the other folks here at Health Systems, the determination was made that we would include those. I think if we have a specific case, as with all of them, we'll definitely take listen to what those circumstances might be. But right now, overall, yes, PSRB clients are included in the home CCO rule.
Who will be responsible for coordination between CCOs and out-of-area providers? The home CCO?
Yes. So that is one of the areas that we've identified that's a challenge is one, home CCOs may not have a provider network outside of their service area. Some I know are actively working on that, and some are working to expand that. But part of that is understanding when the members are out of area. Now, one of the things that we're doing with this rule and the transition piece is that members will be identified before they released. As was mentioned in a couple of the slides, the state hospital is going to be working with those CCOs so that they identify the members, and the CCO is going to know that the member will be theirs, one, and where they're going to be treated, two. So part of that is that they'll know, again, I'll use myself as an example, when Chris Norman is in Pendleton, that CCO can be proactive and understand that they may need to provide services for me while I'm in Pendleton. Now, that may be that the facility that I'm located in has a specific facility or specific provider that they work with, and if that's the case, that facility can work with the CCO and say, Dr. Smith is really who we work with for our primary care needs. Please reach out to Dr. Smith, or Dr. Smith, here's the CCO that you need to work with for Chris Norman while he's in care. Work on getting a contract put in place. We know that's already happening now, but it's definitely not universal, and so that's some of the work that will need to happen to make this work going forward.
Okay, will there be CCO-specific training? There are some that have no involvement at all in the Oregon State Hospital residential transition process.
That's a great question. I think one of the things that we are looking for is if we need to do specific training to some of the groups. This was sent out to a pretty broad group of stakeholders, but I think that some of the CCO questions might be very specific to their operations. So I think for that question, we would look at using one of the CCO work groups that we have on a regular basis as a potential place to do that. We can also look for other questions on what CCOs specifically might be looking for as far as additional training.
When can we expect to see patients discharging from Oregon State Hospital to have OHP benefits from day one that they admit to residential treatment?
I believe that's already happening, but Carrie?
Well, so the date of admit for the client, the benefit coordinators are supposed to be reviewing the enrollment history, but for now they are actually engaging the CCO the 60 days prior to the client discharging.
But I believe the question is, when can they start to see that? And I think the answer is today. They should be seeing this now.
Yeah. We started the process with them.
The first part of August.
First part of August, yeah.
Okay.
Will there be data provided to the CCOs on the expected number of patients that will remain in the hospital area CCO?
Let me reflect the question back and maybe there's if you can help me here. I think what they're asking is if they know for their area how many people are going to be discharged from the Oregon State Hospital to a specific CCO. I think the short answer is that we would have that, but it would be on a rolling basis. So for the members that are going to be discharged in 30 to 60 days, that information will be made to the CCO. As far as how many a CCO might see over a quarter or a year, obviously that depends on the number of members from their home CCO service area that are in the Oregon State Hospital. We don't actually have that data right now. We can certainly look to see if we have that. I'm not quite sure that was what the person asking the question was looking for. So if that was your question, if you're welcome to send us an email directly and we can take it offline and maybe give more specifics about what you're looking for there.
Next question. I think we may have already touched on this, but maybe there's a little bit more to it, so I'm going to go ahead and read it. Can you define temporary placement? When should the individual CCO enrollment remain under the service area or stay aligned with the home CCO? For example, someone may be in a residential setting for a year, where some may be for only a few months.
So again, I think this goes back to the question that was near the beginning of the Q&A session, which was, at this point, we're determining everybody to be in a temporary placement. One of the things that we're going to add to the FAQs is a little more definition around what that might look to be permanent. But the whole point of this is that members, the goal is for all these members to be in a temporary placement and for them to get to their home CCO at some point. I think the question would be is, at what point does it look like that this is not going to be a temporary placement anymore? I think that's the additional clarification that we'll provide through FAQs and subsequent presentations. But at least right now, the goal is that these will be considered temporary until for some reason we have reason to believe otherwise. Part of what we find and what we think by doing this, and we've seen this by doing this over the last several months, is that by having that home CCO know where the member is and be part of that process, they can really engage to make sure that that member is progressing towards their treatment plan to eventually leave. What we don't want to have happen is for that member to really kind of get lost in the process, have no one other than maybe whoever's case managing them at a different level know where they are. Again, the goal is for the CCO to know where that member is, understand what that treatment plan is progressing towards, and then get them back to their home county.
Next question, how will CCOs be able to support individuals living in rural areas where supports are not available?
I think this is a question that is probably not specific just to the home CCO rule. I think that that's a challenge throughout the state in rural areas where we don't have access to some of the services. I think it would be the same no matter if that was a CCO in the area or a CCO across the state. One of the things that we would look to, and this might be something specific for some of the CCO trainings that we're looking at, is if I'm in an area that I don't know that well, how do I collaborate with the CCO maybe that does know or have knowledge on the ground for that area? Are there some things that they can help me with? Again, those are some of the things that we can work through with the CCOs. We've seen some of that happening now, but I think there's some opportunity to increase that.
Also, I would welcome contacting me, Michael Oyster, for brainstorming and collaboration in developing new services and processes. I really want to be in the loop about how that is going for the CCOs, developing these different contracts as well as developing services in rural areas.
Okay, next question. For out-of-area mental health providers for the adult mental health, hold on a second. For out-of-area mental health providers, the outpatient out-of-area VRS class. I'm not sure I understand the question.
Yeah, I apologize. Wait, let's take that one offline because I'm not quite sure what you're trying to get to. But.
Okay. Next question, does this rule just apply to licensed residential programs or also to non-licensed settings, such as supported housing?
It applies to both.
Next question, our clients are not always able to see a doctor when in residential care. Will this change?
Well, we certainly hope so.
Yes, I mean, patients should be able to see a doctor when they're in residential treatment, always. Not just a general physician, but also specialists and psychiatrists. So, yes, they should have access to that.
Would the home CCO be expected to reimburse a provider for routine preventive medical care in addition to behavioral health services?
Excellent question, and the answer is yes. I think that's one of the key things that we wanted to convey through this webinar is that it has been mostly urgent and emergent services out of area, but in this case, because they are temporary out of the area for mental health residential care, the goal is that they would have access to routine physical, dental, and mental health care while they're there.
Next question, is client choice still part of the criteria for determining home CCO? For example, if somebody is leaving Oregon State Hospital and says they do not want to return to the county they came from, is that considered?
I think right now the short answer is yes. If it's a type of care where the member gets to make that decision. One of the things we're looking at is how, particularly for areas that have more than one CCO, that member has adequate information and is counseled on what the different choices are to make that decision. But again, one, I think that's a smaller part of the population that's being discharged that is not civilly committed, that it has the ability to make that decision. In other cases, they don't necessarily get to. So in that case, it would be no.
Next question, once a client is admitted to the Oregon State Hospital, how is or who identifies the home CCO? So how is, once a client is admitted to OSH, how is the home CCO identified and who identifies it?
Oh, the benefit coordinator unit actually reviews the client's enrollment history. And so the benefit coordinators are the ones at the state hospital that are going to be determining the client's home CCO upon discharge.
Before entering enrollment for a person leaving the state hospital, is it possible to confirm with the home CCO that the person should be assigned to that CCO?
So I think the short answer is yes, and actually that is part of the process 30 to 60 days before that member's discharged. I think that the question would be is if that CCO for some reason has information that that's not correct, we certainly can talk about that, although we would be looking at the enrollment history that we have in our system. But yes, the short answer is they will be contacted 30 to 60 days before discharge.
If a member in residential treatment seeks physical health care in another service area, does that physical health care provider need to be contracted with the member's home CCO in order to receive reimbursement?
So like happens every day throughout the state of Oregon, there may be cases where that provider can either have a one-time agreement and be paid at a fee-for-service level. There's a lot of different ways that providers and CCOs can work those arrangements. Ideally, it would be great if that provider is contracted with the CCO for all the reasons that providers and CCOs want to be contracted, including increased payment, including other ways that they can expand their network. But I think that the goal is that, yes, that provider would need to seek payment from the CCO, and the CCO would work to pay that provider.
When clients are placed, each place has requirements to move in. So is the hospital responsible for getting these done in the 30 to 60 days before release?
This is Michael. The AIM High coordinator will be helping to facilitate that process, and the CCO will also be coordinating that process. So the hospital, in part, wants to help with that and to assure that those things are happening, but it really falls to the AIM High coordinator in conjunction with the home CCO to make that happen.
Will each provider need to have separate contracts with every CCO for the temporary placement?
The short answer is no, but the longer answer is that is what we're looking to do going forward, because I think, and again, this is one of the key barriers that we know exists and that we'll continue to work through. There's a lot of reasons why it's beneficial for the provider, beneficial for the CCO, that we want to have a contract in place. We know that may not be realistic, but I think that already exists within a delivery system, that members see providers on a case-by-case or a one-time agreement. I think that what we would see, though, is if a particular CCO works with a particular facility, and there are facilities that they may see more than one member at, it would make sense to go ahead and start that process of contracting with that provider.
When member eligibility is determined before release from Oregon State Hospital, will a lock-in be placed on their file to prevent CCO flipping?
Yes, the benefit coordination group is going to be adding within MMIS a service area exception to hold clients' enrollment into the correct home CCO. And we're also going to be tracking these clients with an MCM indicator within MMIS to ensure that if flipping does happen, that we do enroll client back to the appropriate home CCO.
All right, so I'm going to take just a couple more questions because we're almost at 11:45 now. The first one is, will you email out a transcript of the Q&A? This session is being recorded, so it will be available on the OHA Web Media YouTube channel, and I will send out the link to that video as soon as it's up. Also, the next question is the follow-up session on September 23rd, a webinar or a provider call. That'll be a webinar, which I will also send out with the link to the video so that you can sign up for that. It's on Wednesday, September 23rd from 11 to 11:45. All right, we are out of time. Thank you so much. Please know that your questions are recorded here. I do have a transcript of them in the webinar panel, so we can get those added to an FAQ or get back to you with the answers to those. Thank you so much for being here.